And we are now live here on YouTube, Facebook, and everywhere with the very lovely Dr. Carys Sonnenberg. And today, excuse my background, I'm in the ESK skincare office. We are discussing CBT and the NICE guidelines. Now, there has been a bit of a furore, or furore, depending on which way you prefer to say it, about its inclusion. And so I thought it would be useful to actually just sort of explain to people what it is and why it's there, what the evidence is for it, and basically why it's being included. Because I think the main criticisms have been that it's that women have been told that it's all in their head. They're being patronised. That you can't. The comments that have been going around. No amount of CBT is going to cure my vaginal atrophy. No amount of CBT is going to cure my joint pain. But they're not the things that they're being recommended for. And the things that they are being recommended for are very clear: the vasomotor, insomnia, and mild depressive to moderate depressive symptoms for which there is relatively good evidence. But it kind of made me worry when I was looking at those comments that I thought, maybe people don't actually really understand what CBT is, and they're thinking it's you're lying prone on a chaise longue, just discussing the trauma of your past lives and things along those lines, but that's not what it's about at all. So, Carys, after that incredibly long introduction, what exactly is CBT?
Okay, so this is, thank you very much for having me, by the way, and thank you for asking me to speak about this really important topic, because I know that when you ask me to talk about something, I think that it's going to be easy, and then I start to deep dive into the topic and realize there's much more to it than actually met the eye initially, and actually it is a brilliant thing to do. So just to introduce myself and tell you a little bit about why I think I can discuss this with you. So I'm Carys Sonnenberg. I'm a GP, and I've been a GP for 20 plus years. I work in women's health, and I run a women's health clinic as in contraception, and I spend all my time now dealing with women's health. And I also run a private healthcare menopause clinic as well. So I see women in both those fields, and I have a lot of experience with dealing with women and women's mental health and menopause. So I have done the British Menopause Society advanced training and their CBT training. And I've also done a masterclass 2-day course with Oxford University in CBT for insomnia. So, and I have a lovely NHS service called Talk Plus, where I work in the NHS, that has some people that have got interest in menopause, and they run cognitive behavioural therapy. So I've got a long experience of referring people for cognitive behavioural therapy, and also hearing what people feel when they come back and have had it. So cognitive behavioural therapy. So it looks at when we're talking about the symptoms that we're having, particularly for using it for menopause, you are quite right. It's going to work. There is evidence that shows it works for some things, but it will not work for others. And it really looks at our thoughts, our emotions, and our behaviors. So if I can just talk to you, Fiona, in this way. So these are thought biases that we could consider. So things like catastrophizing. Often that can happen in the middle of the night. So you believe that what has happened or what will happen is so awful that you won't be able to bear it. So it would be terrible if I failed. I'm never going to get through the day tomorrow. If I'm awake at night, and then before you know it, your train of thought is moving on. So these are your thoughts. Blaming others. You may focus on blaming others for your negative feelings. The what if. The mind reading. So he thinks he thinks I'm not able to do this. He thinks I'm stupid, or she doesn't like me. So we have lots of different types of negative thoughts, negative labeling thoughts. I mean, the list goes on. Regrets, judgments. We can have all these things that we think, and then those affect the way that we feel and our emotions, and that then goes on to affect the way we behave. So what CBT looks at is, for example, imagine, Fiona, we're in the BMS conference together and you walk in and walk straight up to me and I just walk off without even saying hello. Okay, so how do you feel in this situation? So do you think to yourself, okay, well, maybe she didn't see me, and actually I'll just go and say hi. So maybe, you know, attempt one didn't work, or I'll go and say hi. Or do you think to yourself, oh my goodness, you know, she really doesn't think anything of me. I'm not even good enough to let, you know, she hasn't even said hi. That must impact upon what I am. And then what sort of emotions do you go through at that point? And then what do? Do you ever come and talk to me again? You know, do you immediately think that I have, you know, done something which means I don't like you? So you see, we could go through lots of different thoughts, couldn't we, and process and how we think. You know, do you think, oh, well, maybe she didn't have her contacts in or something? You know, so it could be a simple explanation, or it could be a very negative thought about our relationship, about me, so, or you. So, you know, so you can catastrophize down the line. So it really looking at how your thoughts are and what you could be thinking in an entire day, and how that will impact upon how you're feeling and what you do then. So it could be as simple as, that's the end of our relationship. You know, you never come and talk to me again because you assume that I have done the wrong thing. Or you go home and assume that you are a failure and you have nothing positive to give. You know, so we can have a lot of negative thoughts.
For me, it'd be the combination of the two.
Yeah, or it could simply be, oh, hi, you know, you didn't see me before, but maybe now, you know, we can talk. So it's really looking at those things. So how can we change the thought process that we have that could be negative, bearing in mind the list is here, you know, of the different sorts of thought biases that we have, which is, there were a lot of different things, actually, very interesting. And then what, you know, so you've got your negative thoughts. And then you need to think, how do I change that pattern? So how do I change that pattern? So I'm thinking in a more positive way, and therefore it's likely to not affect my behavior the next time we speak and we meet each other. It could be something that's much more positive, and maybe I just didn't see you, or maybe I needed to rush off, or something like that. So so that's a gross generalization of what it is.
Well, I did a few years back. Just to sort of bring it back to the idea of people saying that what they're trying to say to us is your problems are all in your head. I did CBT probably about 5 or 6 years ago for anxiety, and I can honestly tell you that the girl who did it with me on the NHS did not care at all what the reason I was there for was. She didn't even ask. It was an academic exercise, really, in ways. Exactly what you were saying. It was what are you feeling? Why are you feeling that really much? And is that feeling realistic? What's a more realistic feeling? And I think I had a real, I've actually had to put it into place in recently. I wrote an article for Health Ed, who I write for every so often, and I rely on their income. And normally when I write an article, I don't get, I don't even get, not get any feedback. And that, but this came back and it was covered in questions. And I thought, oh my God, I've really stuffed this up. I've completely misunderstood what the question was. She's going to think I'm an idiot. She's never going to give me any work again. I'm going to lose the house because I won't be able to pay the mortgage, and you know, and then we'll have to move back to Australia, and that'll be it. And literally, I had gone from zero to monumental catastrophe, living in a tent, you know, trying to survive within about that fast. And in the end, I actually sort of had to make myself sit back and think, hang on a second. You know this editor very well. You've written for her for quite some time. She used to write for you for a very long period of time. So we both know each other's work extremely well. The chances of her thinking, my God, Fiona is a complete idiot, are actually really pretty slim. How do I get out of this then? Send her a decent email going, oh my God, I'm so sorry, I missed the mark on that. And she was like, oh, don't worry. And that was it. But I had literally gone from losing my house and living in a tent to working a way out of it. And it's teaching sort of rationalization process, really, in a way.
Yeah, absolutely. And I have to say that I did those courses, and after the course I reflected, as I do like to do after I do these things, and I I thought, I wish I'd done that years ago. It would have been so helpful for me to know this information a long time ago when I was a young person. Actually, these skills are really very helpful. And I don't agree that people should be labelled as having a problem with their mental health because they have to have cognitive behavioural therapy. Or somebody on social media came back with a comment that the doctor thinks I'm crazy, so we'll refer for CBT. And I had to go, I don't have confrontations on social media. I give my education and that's it. But I have to go, that simply isn't the case. These are skills that people find very positive often, and actually, I believe, are very positive. I don't believe that they are a replacement for HRT, and that is not what the NICE guidance are saying. They are giving these as a choice that we have for women to use as an alternative or as a combination with HRT. And I do offer this to lots of my patients, and lots of my patients do choose to take this up as well, because they've had things that have happened potentially in their past life that they now want to talk about, which they find really helpful. And because they want to have these skills in life, because, when we are, and the changes that happen in the brain in menopause can be profound, and they can be life-changing for some women. And I think anything positive that we can do to help ourselves at this time is really important. So without doubt, hormone replacement therapy is the first line treatment for the low mood associated with menopause and for the anxiety. But lots of people cannot take it, or they choose not to, or actually HRT takes time to work, takes time to balance. Often we see people in clinic who've struggled on HRT for a long time. It was not the right preparation for them because they simply haven't been absorbing it, but because they're on it, they assume that it is right. So they've been struggling on through. So for those people, a combination would be helpful as well. And some people after, cancers, for example, which are estrogen dependent, they can't take it. And they do need to know that there is something else for which there is evidence. So if we're looking at, I just want to have a quick look at this, because I looked at the NICE guidance, which is long. We talked about
99 pages of it, plus 400
through as much as possible in the time that I had. And I also looked at the supporting evidence for CBT. So we have got, so there are two things I'd like to just mention. So they have looked at all the studies for CBT. They've included some and they have left some out, but they've compared treatment as usual, which is hormone replacement therapy or non-hormone replacement therapy, no treatment, including waiting list, and attention control, which is sham cognitive behavioural therapy. So I'm assuming by that they're talking about somatic amplification, which means that you are considering what your body feels like. In my view, I think that's right, which can then impact upon your symptoms, because you're feeling things, as it were. So they've looked at quality of life, vasomotor symptoms, they've looked at sleep, they've looked at patient satisfaction, musculoskeletal symptoms, sexual function, psychological symptoms. So there is a really good document that you can look at if you're looking at the NICE guidance, and you can then see what they've included. So 14 randomized controlled trials across different countries, and they're comparing to treatment as usual, or they're comparing to no treatment. And then you look at the next two pieces of paper, which look at CBT versus treatment as usual and CBT versus no treatment. So they have looked at all the different studies. So that's one lot of evidence to look at if you're considering evidence. And then you also...
They said they looked at a lot of CBT for a lot of conditions there, but in the end, they've only come back and recommended it for three things, haven't they? For vasomotor symptoms, insomnia, and the mild to moderate depression. So they did the evidence backed up for the others.
Yeah, so they've looked at what evidence there is out there, and there's also this book here. So managing hot flushes and night sweats. So this is a really good 4-week. This was given by the British Menopause Society CBT course, and it's written by Myra Hunter, who is a professor of clinical health psychology at the Institute of Psychiatry, Psychology and Neuroscience, King's College London. And she's worked with women in clinical research capacity for over 35 years. And also Melanie Smith, who's a highly specialist clinical psychologist working within the physical health context. And they did an excellent course. It really was very, very good. And this book is something that you can buy and you can read, and it looks at different sorts of things. So it's looking at it's called a cognition behavioural hot cross bun model. So it looks at physical reactions, thoughts, feelings and behaviours. And it also comes with, sorry, I got it all out here. With this book, am I showing it properly? Managing hot flushes. So this is really good. And there's 2 trials here, the Menos 1 and the Menos 2 trials. So they looked at randomized controlled trials for women who have hot flushes and night sweats following breast cancer treatment. And they compared that with usual care. And they also looked at a group of healthy women, so Menos 1 and Menos 2. And they found that that both trials show that CBT interventions are effective in reducing the impact of hot flushes and have additional benefits to mood and quality of life. So we do know that there is evidence there. So this and the feedback from the CBT for some women was really positive. So I think it is something that is a legitimate treatment. It has evidence. It might not work for everyone, but it's amazing. I mean, how amazing is it that we've got other things that we can provide women with as a choice of treatment?
Absolutely. And I think this on the vasomotor. In the vasomotor, that brings the UK into line with the North American Menopause Society, now Menopause Society's new 2023 position statement on non-hormonal treatments for vasomotor symptoms, which recommended CBT, a few other really interesting, hypnosis as well, and I can't remember what the word that, but I just remember hypnosis and CBT were there for that, showing. Basically, they said in the end, it has been shown to reduce the severity and the frequency of vasomotor symptoms. And if you can't take anything else, or you're really struggling with them, even if you're still on HRT, then that's got to be a good thing.
It's got to be a good thing. So it really has got to be a good thing, which I think is a good thing. Now the difficulty then comes in with, so we're looking at it in how we provide it. That's the problem. So yes, we can see that there is evidence, and yes, we can see it's certainly really good for sleep and certainly can be helpful for a range of conditions. So how do people get it? And that's going to be the difficulty, so I can hand on heart say that where I work, I think we need more investment in the mental health service because that is something we need to provide a much better service for our patients. And so it is possible to get CBT on the NHS. However, there may be a very long wait. It is possible to get it privately, and there are some excellent CBT trained specialists out there that really are amazing. And I've spoken to quite a few, because when I started working privately, it became very clear that actually CBT was going to be something that would be very helpful. And there are lots of different types of CBT that are helpful depending on when your trauma has happened or depending on what sort of treatment you need. And then you look at group therapy or individual therapy or self-help sort of treatments. So you can buy this book, for example, and do a 4-week self-help. There are self-help courses. If I look at my own local practice, I can divert people to my local talking therapy, and they can download self-help treatments from there, looking particularly at sleep. I do think some guidance is really helpful. I think doing it on your own, if you've got the ability to do that, is amazing. But I do think guidance would be great. And then you've got to choose, do you have a group or individual?
We have a question here actually which goes to the point of that in a way, of asking about what would happen if you're a generally anxious person anyway, and you're having these symptoms in menopause, and menopause had made them worse. You also have anxiety on top of it, and you went to one of these appointments. What would happen at the first appointment? How would that normally go?
What would happen at the first CBT appointment?
Yes.
At the doctor's appointment.
If I go to see you, what would you do? I'll tell you what happened at mine while you're thinking. Basically, when I went to mine, basically, she sat down and she sort of said, so you've got anxiety. Here's a workbook. I'm going to show you how to do this the first time. Let's have an example of pretty much like you did. You walk into a room and your friend ignores you. How would you take that? These are the ways you're going to work through that. Then here, take the book home and do this for 4 or 5 things this week. Come back next week and tell me how it went. That was how mine went. How would you do it?
Okay.
It be quite the same.
Right. So that doesn't sound like you feel that's a negative. That was a positive experience. I'm getting the vibes.
I literally was I was in a bad state then. I kind of thought, wow, you really just don't care about why I'm here at all, do you? Okay. Yeah, that's right. It was a beautiful exercise. So, yeah.
Okay, so right. I'm speaking personally from my own opinion now. I don't think that sounds very positive. I think there's got to be a degree of empathy when you're doing these sorts of things. So this is patient handouts information. What should I help showing this now? Right. So the course that was the group course that we were discussing setting up potentially was a 2-hour, the 6-week course, which was in a group. And the reason that was felt to be helpful was doing something in a supportive group with other people who are also experiencing the same symptoms can be very supportive, in not just the fact you're present in the room, but that actually you develop a connection with other people, which is thought to be positive if that's your thing. And the way you're supposed to do it is to look at a biopsychosocial model. So you're supposed to explain, and I always like to do this if possible, explain why you are feeling this way, because it's immensely reassuring to understand what's going on in your body if that is if you're able to explain it. So you explain the hot flush. So here's a little thing. You're looking at, hang on. Yeah, okay. We've got the thermoneutral zone. So you're explaining what is happening to you during a hot flush. Why are you getting it? What's happening in your brain? And what is going on? You're also then explaining things that can make it worse, like anxiety, like stress, like spicy food, like rushing about. So how do you keep your body temperature within that thermoneutral zone, and what might make it worse, so that when you know that you are doing something stressful, it brings on a hot flush, that actually you think, okay, well, that was brought on by that hot flush, so you can rationalize it. And then you're looking at different,
sort of take the randomness out of it in a way, so you're not thinking, my God, these are controlling me, I've got some sort of form of control over them in some ways. I know why that one happened. Is that the logic behind that?
Yeah, well, yeah, I think a little bit. I think that sometimes they just happen all the time, don't they, to some ladies? And really, there's nothing in their lifestyle that's brought this on. This is simply to do with the estrogen changing in the brain, and then so that's what's going on. So I think we're talking about this in a way in which we're making it seem very black and white, but we know that life isn't black and white, and actually for some women this is so difficult to manage that this may be helpful, but so explaining to them why it's happening may be helpful. And then you look at, they give you little sort of prioritizing, so stress and lifestyle, prioritizing your well-being, so healthy lifestyle, because we do know that makes a massive difference. And then you've got problem solving, so identify the problem. What are your options? Things like, what would you say to a friend now, for example, who is suffering from this? Because we've always got great empathy for our great friends, haven't we? Whereas we don't appear to have the same often for ourselves, the same degree of kindness that we would have and compassion that we may have. So So writing it down can be really helpful. What can we do to help ourselves? What are the pros and cons? So yeah, there is a homework basis of it. So it's a discussion of why this is happening. It's a discussion of, so they may give you scenarios. So, you know, Mary sat at work one day, she had her door open, everybody kept coming in and talking to her. She found herself getting more and more anxious. And she wasn't able to finish her day at work. She ended up working really late, you know. So then thinking, well, what would you do to help Mary in this situation? What could she have done to help change how she felt, what she behaved, why did she stay late? You know, those sorts of things. So it's little problem solving things. So yeah, there is a degree of work through the handouts, because I think that is also quite helpful for women to ponder and to think about things and to have time. Because I think if you're trying to rush somebody through something you're almost forcing them to make a decision maybe they haven't quite thought through. So yeah, they do need to have a think. They need to give it a go, and to be aware that some days will be better than others, and then to come back the next week and talk about how it went. So that's what the whole situation is. I know it may have seemed like you were handed out, okay, well, this is what you've got to do, and here's a box, which actually, so if it was discussed in a more positive way with you, then you may have found that much more helpful. And it might be that you don't like the group session, you actually much prefer to do it individually, and it might be that actually you much prefer to do it on your own, and you'd much prefer to get a book, you'd much prefer to have you know, this you can buy, and it's got some great things, so relaxation, you know, it's sleeping charts, managing menopausal symptoms. So I think this is good.
Practical stuff.
I feel like I'm putting my head above the parapet here, but I do think it's good. I really thought it was really helpful, and I don't think it should be the first line treatment, and I don't for people who got choice, but I do believe it's really helpful for all of us. I think pretty much. It's a good skill. It is a good skill, and it is helpful. And sometimes, you know, it's really nice. It is nice to have other things to offer. And my own personal feedback from patients have been that CBT and hypnotherapy have been really very helpful with menopausal symptoms.
Yeah, and it's not saying it's all in your head. As just to reiterate that, it's more saying, okay, you have a problem, but here is a tool set that you can use to manage it. So I think it's a different way of actually looking at it. Moving to sleep for a moment, because that's the other one that it seems to work quite well for. I think some of the studies were showing that it works for around about 60 to 70 or so people. It increases the duration of your sleep, which is a nice thing, and also makes it faster for you to get, or quicker for you to get to sleep. So if you're having because you've done the CBT training for sleep, so what do you say to people about sleep? How do you manage that one?
I think that's so interesting, and it was a really interesting course. So it looks particularly at how the importance of so sleep hygiene, for example, so preparing your body for sleep and winding down, what to do if you wake in the night. So when I speak to people, if they wake in the night, some people can really find that very, very stressful to wake up in the night. So they don't often have an understanding of their own sleep pattern, in that we all wake up in the night and actually then we go back to sleep. The pattern of our sleep going into sort of lighter sleep and deeper sleep, when that might happen, what could affect it, like alcohol, like stress and anxiety, what to do the early night, you know, just, I mean, I don't know about you, but when I was brought up, if we'd had a really bad night's sleep, it would be, okay, well, let's have an early night. And then you'd spend like 16 hours in bed. No one's ever going to sleep for that long. So keeping your sleep the same, your timing the same, getting daylight on your skin, avoiding stimulants. So understanding what the half-life of caffeine is, you know, say 7 to 9 hours, for example. And I'm talking to people who metabolize that properly. You know, if you've got a genetic snip in your caffeine metabolism, it's going to be quicker or longer. That is there in your body. But how to think in the middle of the night, if you do wake up, to think to yourself, okay, well, I've been awake for about 15 minutes. I need to now maybe sit on the end of the bed rather than actually lying in this position and tossing and turning and being anxious. I'll go to a new room and wait till I'm tired and then come back to bed. So that was a very good tip. And the not to worry. So we can catastrophize very much in the night. Everything is much worse, isn't it? Because we're worried, it's dark, we have no one to talk to. So all these things can get much worse in the night. So just making sure that we keep our sleeping routine the same. We get up, we go to bed at the same time. We try and avoid, if possible, we avoid a daytime nap, but if we need one, trying to have it early in the day. So just some really simple tips that were actually very helpful, and that we're teaching our body how to behave. The bed they recommend is for sleep and for sex, not for watching the television or being on your phone, or something which is teaching your body that that's what you do in that bed. So that was very helpful. And then the CBT can come in. So if you wake up, not to immediately think, oh my goodness, I'm never going to make it through tomorrow. And then your anxiety, you start to become anxious. So your blood pressure goes up and your breathing rate goes up. You start to get a bit sweaty. That brings on a hot sweat or a night sweat. So then you've got to get up and change your clothes. Whereas if you thought to yourself, okay, I'm awake, this is a bit annoying, but actually it's okay. I'm just going to rest. And if necessary, I will sit up and change my position, or I'll get up and then I'll come back to bed. And actually, there is maybe a chance that you will get to sleep quicker, and then your pattern of thought will be that you get back to sleep rather than lying there being stressed, having a hot sweat. So that's why I think it can be really helpful, and certainly it has been helpful. And the course was really very interesting with the pattern of thoughts and behaviours and emotions and physiological changes that happen in the body when you start to get stressed and worried.
Yeah, and you really do, don't you? I've now started, when I lie awake like that, thinking of what songs would I sing if I went on The Voice. That's always a fun one. And this is my hot tip for getting back to sleep: focusing on putting your eyes down. It takes a huge amount of effort to actually look down. But after a while, apparently, I was talking to some of my Stokes about this, who's a CBT psychologist a while ago, and she said, yes, I've started doing that too. And apparently that's the sort of the position where your eyes would be if you were in reading, and it sends a sort of a feedback sort of message, she thinks, to the brain somehow of just sort of
interesting. Yes.
It takes about 4 or 5. Bad night can take me 5 times of eyes down. But at least when you're doing that, you're actually only concentrating on that. So it actually clears those other thoughts out. And so if nothing else, you're concentrating on that rather than all of those distracting things that you think are about to ruin your life.
And we should probably mention for Dr. Louise Oliver, and I thank her very much for all her support with breathing, the difference, the problems that can happen with sleep, so we do have to really consider our breathing. So we can use our breathing to change ourselves from a sympathetic to a parasympathetic nervous system. So that means a stress nervous system response to a more relaxed rest and digest response by using our nasal breathing. I say I shouldn't take a big breath in through my mouth then. So should be using our nose to breathe. And then we need to consider sleep disordered breathing at night. So we need to consider obstructive sleep apnea, snoring, which can be really impactful upon our sleep and also upon our health and risk of future health conditions. So now when I take a sleep history from people, I always ask them, are you snoring? Do you have any pauses in your breathing? How do you feel the next day? Because it could be that you're not snoring and you still have these sleep apnea symptoms, and restless legs as well, which can be quite common. So is there enough iron in your body? What's causing these symptoms? Restless legs. Interestingly, I had a lady recently whose restless legs got much better when the beta blocker for her migraine prophylaxis was reduced. So medication can also impact upon restless legs. So there are lots of things that we need to think about when we consider good quality sleep, and not just looking at CBT, but if you are waking in the night a lot, especially waking choking, or you're thinking you're having breathing problems, then could that be a diagnosis? Because it's much more common than we have thought.
Yeah, much more, because actually the story that came back with all the questions in it was not exactly that. Actually, it was about danger, it was about driver fatigue and sleep. And one of the statistics that actually came up, it was 40 to 60% of postmenopausal women with sleep apnea. and they reckon it was a major underestimate, even with the group that
I
most
think
of
it's more. I think Louise did a post today, which was really interesting, and it was more than that. I mean, she's got some fantastic evidence and does a great course on breathing, which I've done, and my husband. So looking at, because he was a snorer, so it was impacting upon my sleep. So then I'm catastrophizing in the night, which it's a horrible thing, not being able to sleep. So we're talking in this way, but really genuine insomnia is when you have had 3 months of disturbed sleep, which is affecting your quality of life, which is common. So insomnia being 40 to 60% of women in menopause, which can also be then linked to mental health problems and linked to future risk of cardiovascular disease and metabolic health problems. So sleep quality is really important. So actually, if CBT has got a lot of good evidence for that, then that's definitely something to consider as a positive for symptoms in menopause, in order to look at supporting our health now, our sleep now, because sleep has an impact upon weight control. And if you're exhausted the next day, you're more likely to eat more. So therefore and crave foods that may cause you to gain weight. And we really need to look at helping women, support women with that as well. So everything is linked, isn't it, together? So cognitive behavioural therapy can be a tool for us to use alongside HRT, if that's possible and a choice, or instead, then I think that for the right person, that is great. Getting it has got to be, we can look at the self-help, certainly. We can look at what we can provide on the NHS. It is available privately. It can be done individually or as a group, and it's usually a 6-week session. Usually there's a 2-hour thing as a group with some homework. And really thinking about how your thoughts are and what is that reflecting in your feelings and your physiological changes in your body and your behaviors to do with that, and is that something you feel might be helpful? And sometimes you need to have it more than once. Sometimes people will say to me, oh, I've had CBT a long time ago, and maybe I need to remind myself about it, because it will be something that often as talking therapies will be introduced.
I think this is the problem, actually, is calling it talking therapy. I think that's what confuses people, because that's when people do think they're lying out on the chaise longue, discussing everything that's happened in the rest of their lives, and having to spill out emotional stuff that they don't really want to discuss with people. I think that's where they get very confused, because this really is cognitive therapy.
Yes, you're right. Yeah.
I think it's poorly named.
Yeah, I think counselling is not the same as CBT, is it? So counselling, if you go and see somebody who's going, we would call them in the UK, we'd call them a counsellor, wouldn't we? So you would go and talk. CBT is not the same as that. So it really is looking at sort of your little bubbles of thoughts and feelings and behaviors, and how to look at changing that. So it's a different sort of treatment, in my opinion, what it is.
Yeah. I really honestly do think that it should be taught in schools. I think it's a basic human skill that all of us need for resilience, apart from anything else. That's what really comes down to. It makes it just so much easier to function when you're not going off on a tangent that isn't realistic.
It is helpful. I mean, I really did find it helpful. I came away and thought to myself, this is actually, this was a really helpful course to go on. So I looked at it in much more detail. I'd always understood what it was that people were having, but not quite in as much detail, where I'm looking at the particular impacts of the way that I or a person may be feeling and thinking, and thinking, actually, this is really very positive. It's just really accessing it. That's the difficulty. And certainly it can be used by every single person, really helpful in a helpful way, because when you become low and anxious and the difficulties come in menopause, sometimes it's difficult to think clearly about what might be helpful, because you just can't see a way out of that time at that moment on that day. And all the skills that we can have are going to be a positive thing from that, in my view.
Yeah, absolutely. In terms, if you're a practitioner, just because I know a lot of practitioners watch this, is it difficult to access training to do this? And if you, yeah, is that so? I was going to say, I'll leave it at that one. If you're a practitioner, is it difficult to access training to do this?
Are you asking me?
Yeah.
Oh, well, I mean, I can only tell you about the training that I've accessed. So it cost money to do it through the Oxford University one, and the waiting list for the British Menopause Society one was long, but a few months. I mean, so that was good, and I know lots of other people who've done it. So British Menopause Society specialists. So it's possible for us to access it. The difficulty is that when I see somebody for a consultation, I can help by giving some skills, but I don't run the course privately. It's the access to having it like this. I think that's the struggle that's going to be. So when we say to women, okay, look, this is available, we need to give them some ideas about where they can get it. So if they're going to be on a year-long course, because there are not enough specialist trained, for example, then that's not good enough. So they need to be given something that could help them in the meantime with somebody who could help. So that's really, I think, where I think we can see there's evidence. We can see there's been a lot of amazing work with this. We can see it's an alternative. It's how do we give it? Because it's not that this isn't new. We've been doing this for a long time. It's not a new thing. It's just becoming more spoken about now, which is brilliant. But how do we get it to people? So that's the difficulty. So we know that we can do it online, we can do self-help, we can do group and individual, but it's where do women and people, where do they get that from?
Yeah, I wonder if that's actually something that the Menopause Research and Education can actually look at. Somehow they, pulling together a course for doctors and other health professionals who provide counselling and those sorts of things, so that they can actually, do you think, was there anything that was particularly specific about doing the CBT for menopause as opposed to a general could a general CBT course easily be, or a practitioner who's done that, easily transfer those skills to menopause or insomnia?
I haven't done a general CBT course. I'm not sure how different that would be. I mean, this was really geared towards hot flushes and insomnia. So I would suggest this was specialist to that. So we were sent away with the book, with sort of, so everything that we would need to be able to set up this service ourselves as a group, and it really was teaching us what to do. But also teaching us about what it is and what's helpful. Particularly with sleep and hot flushes. I'm assuming the skills would be transferable in some ways, but I'm sure, someone who's a specialist in CBT would be able to tell you much more, because my understanding now is a bit better, but there is a huge amount that I didn't know when I've been talking to specialists, particularly about different sorts of therapies that can be used. So I think I can only talk about what I know, and that's this course and the other one. I don't know other things. I mean, therapists train in these specialist areas for years, don't they, for this? So it's something which is, I wouldn't be able to discuss the complexity of that.
So in theory, for them, an addition would probably be really quite easy for them, as opposed to somebody starting from scratch. But yeah, and then yes, maybe we should work on some way that we can actually then deliver a course, group sessions or something to mere mortals, to the rest of us who need it.
Well, yes, everyone.
It never stops on what we can do.
Yeah, we have to. I think I do think that, having read particularly what the NICE guidance says, I think it's reassuring that we've got this available. But I can see the difficulties in the comments that may come in regards to the access.
Now saying that the access is an issue.
Yeah. I'm really sorry about that. Pardon?
Even getting through the receptionist to the GP is a nightmare, she's saying, let alone getting access to the actual
Well, I do know that, yeah, because I try and phone GPs often to sometimes to discuss patients with Rowena Health and to discuss and to make sure I've got the email address and things. And yes, it's just some really are. And I think to myself, goodness, how do people get through at all? Yes, there was an interesting thing on the news this evening or this afternoon talking about funding for the NHS, particularly with regards to we need more staff in general practice. So we need more doctors in general practice, particularly in order to be able to do what we need to do. But there are lots of GPs out there who are trying to get a job, but they can't get a job because there's no funding. So so really, there's I know at least two of my my friends who would like to be able to get a role in general practice, but even as a locum, there's no funding for them to do that now.
No.
Yeah. Yes.
Wow. We've got a crisis where people can't get to see somebody, and you've got two people who you know who can't get a job as a GP. Wow, that is just jaw dropping. Just makes no sense.
Yes, I think there's just it's something that we need to certainly look at, don't we? I mean, it's not my area necessarily to look at all the complexities of that, but yeah, it's just not fair. And I'm sure this talk isn't all about the NHS funding, so but we do need to work on something that means that people can access the care that they need.
Absolutely, because Carol here is saying she had CBTI for insomnia. It worked, but it took a while. But I was able to come off sleeping pills and get my sleep back on track, and that is a good thing. So if you were writing feedback to the NHS on these draft guidelines, what would you be saying, or what would you encourage others to say?
Are we just talking about the CBT?
Yeah, just talking about the CBT. Let's not go to the areas. Okay,
because they really are. You know, when you asked me yesterday, I thought you wanted me to talk in general about the NICE guidance. So, I mean, it's immense. It's huge, isn't it? The document. So it's amazing that we've got a next review, as it were. So what do I think about it? I personally feel it's a positive to have this discussed as it is. It's got to be a good, positive thing. Yeah, that's my view.
There you go. All right, brilliant. Shall we leave it there?
Yes.
So can I, because I always forget this, can I remind people to subscribe to the MREF YouTube channel down there, or the Harley Street Emporium one? At the moment, I am streaming with both of them. Eventually, I'm going to move all of the menopause stuff onto the Menopause Research and Education Fund one. This will be a work in progress. And yes, because we are about a bit of good news, very good news. I will be we now have the funds that we need to apply for the menopause charity status, which is great. I've done the business plan. That's what I've been writing on for the last few days. My accountant said to me, oh, it'll be easy. You just put a couple of figures in. It was literally 3.5 days of solid writing. But hopefully early next week, I will have all of the documentation and everything ready to put in the application, and fingers crossed we will have full charity registration status by the beginning of the new year. So that is
so happy for you. You've worked so hard. You really have. You're amazing. Thank you. Thank you for asking me to get involved in all this. It's really good.
I couldn't do it without everybody. Everything's a team effort, really, isn't it? So so that is a very good thing. So any support that people would give would be very, very highly appreciated. Yay!
Absolutely. And no, it is amazing. That's what we need. We need more evidence so that we can reassure women in a much better way, because there are big gaps, as you and I both know. So we need to be able to be more clear with that as much as we can. So thank you for all the work you're doing.
Oh, and thank you. And if people want to find you, darling, where do they find you?
So I've got my Instagram account, which I've got two. So Dr Carys Sonnenberg and Rowena Health. And then my Rowena Health website is there with some bits and pieces on there as well. And LinkedIn, I'm on as well. I forgot my thing. And Facebook. Oh, there's various things around. Instagram is a good one.
Brilliant. All right. Thank you again. I will end this here on Facebook for those of you who are there.
Merry Christmas.
Oh, yes. Merry Christmas. And yes, Merry Christmas. I'll probably talk to you before then, and I'll probably drag you back on here before Christmas. You never know.
I'm going skiing.
That's all right. It doesn't matter. Go on. Anyway, if I speak to you, thank you and happy Christmas to everybody, and I will talk to you soon. Take care.
Yes.